share your screen? Okay, it's okay. I welcome Dr. Valenti, and I think already he had given short introduction. And also in this time, I would like to thank Dr. Raju from Biotech, who had he had a communication with him all the time. Dr. Valenti has started his shoulder work in 1995, so he has got almost around 27 years of shoulder work, and he has got a vast experience in shoulder arthroplasty, arthroscopy, nerve reconstruction, and tendon transfers. In 2003, he was one of the designers of the complete convertible shoulder prosthesis called Aero Shoulder Arthroplasty. In 2004, Dr. Valenti was president of French Microsurgery Society, and since 2008, he is the general secretary of this French Microsurgery Society. And in 2013, Dr. Valenti organized PH-Hardy, the first Paris International Shoulder Course, and he had done the 4th edition in 2019 with more than 700 attendees and specialists of shoulder surgery with life surgeries. He is also past president of French Academy of Orthopedic and Traumatology and past president of French Orthopedic Society of Shoulder and Elbow. He has over 50 publications on PubMed and has written 4 books, including Tendon Transfer for Irreparable Cuff Tear. With this introduction, I welcome Dr. Valenti to talk on his goes on his talk. Can you share your screen, Phillipe?
Okay.
Yeah.
You see the screen?
Yes, we can see. Thank you.
Okay. Okay. I would like to thank you a lot, all the team, all the members of the India Arthroscopic Society. They are good friends, and it's a great pleasure to share with you this subject regarding the tendon transfer in massive posterior superior cuff tear. I invite you, of course, in Paris in the best period in the future to visit me. You are welcome, everybody from India, of course. So this is my disclosure. The first point is to define the posterior superior cuff tear. This is a lesion of the supraspinatus, infraspinatus, and sometimes a deficiency of teres minor. And when the tendon is not reparable, you have to discuss many tendon transfer. Latissimus dorsi, lower trapezius transfer, episcopo, this is latissimus dorsi isolated or combined to teres major around the humerus. And if there is a pseudopyretic shoulder, you can combine tendon transfer on reverse prosthesis. So the first point is, what are the contraindications of tendon transfer? In my experience, if you have no subscapularis, if you have no deltoid, if you have no glenohumeral arthritis, if you have a pseudopyretic shoulder, you cannot do any tendon transfer because tendon transfer is not enough stronger to stabilize the head, and you have to use a reverse arthroplasty. When you have a deltoid plasty, you can combine pectoris major transfer to restore deltoid, and for me is an indication of reverse arthroplasty. It's so rare, but sometimes you have deltoid palsy and you can do a reverse arthroplasty. So if we discuss about latissimus dorsi, you know that this muscle is very big. You see that the insertion along the spine of dorsal spine, lumbar spine, iliac crest, and this is a very large muscle which turn around the teres major to fix to the anterior part of the humerus. You see that the pedicle is 10 centimeters from the insertion and deep to the latissimus dorsi. The important point that the action of this muscle is not external rotation, is not forward elevation. The primary action is adduction, medial rotation, and retropulsion. It's very important to remember that because sometimes you use latissimus dorsi, and if the patient doesn't understand what happens, if he's not motivated for the rehabilitation, the latissimus dorsi doesn't restore any external rotation. I think that there is the rehabilitation procedure is very complex for some people to restore external rotation. It's very different than lower trapezius transfer. So this is a good paper of French guy Herzberg, who studies the biomechanical compare of the depends of the site of fixation of the latissimus dorsi. If you fix to the insertion of the infraspinatus, you can restore external rotation. If you fix more anteriorly to the footprint of the supraspinatus and infraspinatus, you can restore forward elevation and in abduction external rotation. How does it work, the latissimus dorsi? What is the function of the latissimus dorsi? If you put the latissimus dorsi to the footprint, it will stabilize the humeral head to facilitate the action of the deltoid. This is an active tendon transfer. It's not only a tenodesis effect. There is a contraction of the muscle, and when the muscle contracts, it goes down the humeral head to obtain a good elevation, forward elevation. If there is a deltoid palsy, of course, it's a contraindication of the tendon transfer because the main motor of the shoulder is a deltoid. And here, if you don't have the cuff to counterbalance the deltoid, you have no forward elevation. You have to understand very clear this point. Indication for me of latissimus dorsi, you have a good deltoid, you have a painful shoulder, is not pseudopyretic, but you have a limited active anterior elevation and you have a weakness of external rotation. I show you this case. This is a woman and she tried, and it's not so easy, and she helped with contralateral side. This is for me, with a painful shoulder, the perfect indication of latissimus dorsi. You try to do rehabilitation during 2 or 3 weeks, and if she is not able, you see that the major rotation is perfect. But if you analyze that, you see it's perfect, but it's not so easy. You see? You try to forward elevation, but it's not possible. And I think that external rotation is correct. It's not so bad. There is infraspinatus, but maybe it's not possible to have a good forward elevation. This is for me indication of latissimus dorsi transfer. After you do imaging and you know the Guttalier classification, and if there is 3 or 4 more fatty infiltration than muscle, I think that if the tendon is retracted at the level of the glenoid with atrophic muscle and fatty infiltration type 3, type 4, even you release the cuff, even you release the deep part, the superficial part of the cuff, is not possible to repair anatomically the cuff, and for me is a good indication of latissimus dorsi transfer. Subscapularis should be good, or sometimes there is a superior part who is destroyed and you repair the superior part of the subscapularis and you can do a latissimus dorsi transfer. You see in this case, it's very interesting. This is the supraspinatus, this is the infraspinatus. The teres minor is still correct. Subscapularis is still correct. And if the tendon is retracted like that, you see that is retracted at this level. Even you release is not possible to repair anatomically, and you can do latissimus dorsi as a cuff augmentation. This is a concept of the cuff augmentation. You see that this is here, is not reparable. This is the inferior part of the infraspinatus. And you can do sometimes a partial repair. We try always to do a partial repair. And you have many techniques described by Burkhardt, advancement or margin convergence or medialization. And you can do this technique if it's possible, but you will reinforce with the latissimus dorsi transfer. If you read the literature, many papers regarding latissimus dorsi transfer, It was described firstly by Gerber, of course, open technique described. And you know that if you have no subscapularis region, if you have a good teres minor, no atrophic, you have a good result of latissimus dorsi transfer. I show you a video because we have time to show you. This is a semi-beach chair position. You do axillary approach, and this is a small incision, and you detach the latissimus dorsi. The key point is white aponeurosis band. You see that this is a right aponeurosis band here, and you detach from the teres major. Sometimes it's not easy. You detach from the triceps, and after you detach from the humerus. And after you have 10 centimeters, and you release the latissimus dorsi from the skin, from the teres major, from the deep part, and you reinforce the aponeurosis band with 2 Krakow suture. I think that you can do on 5 centimeters 2 Krakow suture with 2 color, and I use a Vicryl on the superficial part of the aponeurosis band to be sure that there is no twist during the way to the humeral head. You have 2 colors, and after I put, you see, this is a pedicle, it's 10 centimeters. This is the excursion of the latissimus dorsi. You have to release, and you have to simulate the next position of the latissimus dorsi. The fixation on the humeral head, you can use an arthroscopic technique, and you use 4 portals, as you do when you do a tenodesis of the biceps and repair the calf. You see, this is a calf. I try to repair systematically, and sometimes this is a return, and sometimes this is a case of the return. You see that this is the first anchor, the previous anchors. And I decided to reinforce a new repair with the latissimus dorsi. You are posteriorly between the deltoid and you see the deltoid on the left side, on the cuff, the remaining cuff on the right side. And with a shuttle relay system between the axillary area and the posterior portal, you pull the latissimus dorsi posteriorly. You see, this is a latissimus dorsi posteriorly. It's important. And after you push it into the joint, and you fix it on the footprint. You see, in this case is a recurrent tear, and I fix first with 2 anchors. The first anchors at the level of the supraspinatus with a Swivelock knotless, like that. And I use a second anchor here, laterally. And after, I will repair partially the calf, because it's possible. When I have a recurrent tear, and when the muscle is not so perfect, and there is a fatty infiltration, I prefer to repair or do a new repair like that, but I do a cuff augmentation with the latissimus dorsi. And now I prefer this technique for recurrent tear, because I think that if you have a risk of a new tear, you have the latissimus dorsi to compensate the failure of the calf. You see here, I use a shuttle relay technique with a needle. It's a very simple technique. And after I pull all the strands, I like to use 4 or 6 strands to decrease the tension on each strand. Okay. And you can reduce partially like that, you see, and I use 2 anchors. You have the tendon transfer on the footprint of the supra and infra, and you repair partially the calf, and you have the final result. All the head is recovered, and you have a good fixation, and you see, this is a tendon transfer, and this is the calf repair. So regarding the post-operative, after latissimus dorsi, I put a sling for 6 weeks, and after I start passive range of motion and active range of motion. So I published in 2016 35 cases of latissimus dorsi. It was the primary operation in massive curve tear, and you see that you win 42 degrees in forward elevation, you win external rotation 11 degrees. The function of the shoulder is 66%, and the constant score is 60, between 60 to 70. All the functional scores are improved. And this is another study I published in 2017. I compare the group A, this is a primary, this is a repair of the partial repair is a group B. Partial repair with latissimus dorsi transfer, and in group A, isolated latissimus dorsi transfer. And you see that if you are able to repair, the cuff is better regarding the result. I recommend to do systematically a partial repair combined with a latissimus dorsi transfer. We had 4 complications, 2 hematoma, 2 rupture. Sometimes you have rupture of the latissimus dorsi transfer. And my recommendation now is not to tie too much. It's better to fix the latissimus dorsi transfer to the footprint of the infraspinatus if there is not a big excursion of the tendon. If you have a big excursion, you can put on the supra. If you have not a big excursion, you put to the infraspinatus. But there is no difference in the 2 groups. And this is a case of the young man, 56-year-old sportman. It was painful. You see that there is a superior migration of the humeral head. Supra and infraspinatus are torn. There is no strength, but he has a good external rotation. You see that he has a good external rotation and no arthritis. So you do MRI or arthro-CT scan as you want. You see that a retracted supra and infraspinatus, very large tear, and but the teres minor is good. And you see that the subscapularis is good. This is a good indication, but there is no supra, no infraspinatus. And you see that there is a good teres minor. It's the reason why there is a good external rotation. And you can do a latissimus dorsi. This is a result. And now we have 10 years follow-up with this patient, and we were very, very happy regarding the results. So the first conclusion, I think that latissimus dorsi is a good procedure, is an effective procedure to relieve pain and to improve the results. And I think that the indication is clear for me. The teres minor is good, but you are not able to repair the supra and infraspinatus. Why? Because the supra and infraspinatus are atrophic with a fatty infiltration more than 2, 3, or 4. And more now, when I have recurrent tear with patient very painful, good subscapularis, I combine partial repair with a latissimus dorsi transfer. And if you can do partial repair, is better for the final result. And we think that this is a dynamic curve augmentation. It's not a tenodesis effect. It's not that the superior capsular reconstruction or the balloon is completely different. This is a tendon, this is a muscle, and this is a dynamic curve augmentation. Regarding the lower trapezius, it's not the same indication for me. You see that indication is supra, infra, and teres minor deficiency. For me, this is the indication of lower trapezius transfer. Remember that we use this tendon transfer in paralytic shoulder. This is a brachial plexus lesion to restore active external rotation. And Bassem and Jaime Bertelli in the same period describe this technique. And to go to the humeral head, he used a tendon allograft. Achilles tendon allograft. The first publication was a poster in the American Academy with Lisa Galatz and the team of Yamaguchi, and he reported 14 cases of lower trapezius transfer with this technique. It was not the same indication. It was a posterior superior curve tear, but many times the teres major was functional. But it was very interesting because she did an electromyography study to prove that there is a co-contraction. She did ultrasonography to show that there is a mobility of the graft, and a very nice result regarding external rotation and the strength. This is the first poster, first publication. Bassem reported in GSS a very good good series of with open technique, with Achilles tendon allograft. But you see that in this situation, teres minor was functional in 70%. And for me, it's not a good indication. I prefer to do latissimus dorsi in this indication. But it was very interesting to show that you win external rotation, you win active elevation on pain relief, on the function of the shoulder is 78%. But if you analyze the article, it doesn't recommend this technique if you have a pseudoparatic shoulder or if you have a forward elevation that's less 60 degrees. Remember that the lower trapezius, this is a muscle, insertion is between dorsal and lumbar spine, and the end of the muscle is in the medial part of the scapula, the tendon to the scapula. There is a tendon, and you can isolate a tendon. Regarding the innervation, this is a spinal nerve. Spinal nerve go down 2 centimeters medial to the medial border of the scapula, and it's very dangerous. And many times I recommend to use electrostimulation during the operation to identify clearly the nerve. And most important for me is the co-contraction of the lower trapezius when you do external rotation. And this is for me the key point of this technique. But it's too short to reach the insertion of the infraspinatus. If you want to restore active external rotation, you have 3 possibilities. You can use latissimus dorsi, but you see that less strength, but big extrusion. You can use teres major, you can combine less strength, good extrusion. But the closer is the lower trapezius. It's an evidence that is close to the infraspinatus, and that is the best tendon transfer for me to restore external rotation. This is a good paper of Robert Sattler. So he was fellow in Mayo Clinic a long time ago in 2012. And he reported that if you want to restore external rotation arm to the body, the best tendon transfer is lower trapezius. If you want to restore external rotation in abduction, the best is latissimus dorsi and teres major. And in my practice, I try to respect this biomechanical study, and I have clinical proofs now that it's working very well. So this is anatomic dissection. You see, this is a lower trapezius with the fascia of the infraspinatus. And you see that this is the same way, same direction that the infraspinatus. It's the same direction. And is agonist of the infraspinatus. Excursion is close to the infraspinatus, but the strength is left. And if we compare with the latissimus dorsi to external rotation, it's clear that biomechanical concept is better than latissimus dorsi. The indication for me is a patient with a painful shoulder, and there is no active external rotation. You see that? This is a lag sign. He's not able to maintain the arm in external rotation. And why? Because there is no infraspinatus and there is no teres minor. And you see that sometimes there is a Hornblower sign if the patient is able to do a forward elevation. You try always to do physiotherapy during 6 months, but if there is a failure, you can propose this operation. Here, you see that these patients, this is a lag sign. And you see that this is an hormonal sign. She is not able. She is able to do a good forward elevation, but she is not able to do external rotation. Why? Because there is no infraspinatus, no teres minor. After you go to the operating room and you put your arthroscope on, always you try to repair. Of course, always you try. You decided to do a lower trapezius, but you try always to repair partially the cuff. This is very interesting case. It's a dancing professional player, and you see that he has a very nice deltoid. He has a good external rotation in abduction because this is a posterior deltoid, but he has no external rotation, the arm at the body, because he has no teres minor, no infraspinatus, no supraspinatus. He has a good deltoid. He has a good subscapularis. It's the reason why the forward elevation is perfect, but he has no external rotation the arm at the body. And for the patient, is a very nice indication of lower trapezius transfer. This is a technique. I do a small in B-chair position. I do a small incision posteriorly. Now I do horizontal incision across the medial part of the scapula, and this is the spine of the scapula. This is the superior medial angle of the scapula. And I use a horizontal now incision. And to fix to the humeral head, I use 4 portals: posterior portals, posterolateral, anterolateral, and anterior portals. To reach the insertion of the infraspinatus, you have 3 techniques: an allograft, Achilles tendon allograft, but it's very expensive many times. It's I had an infection with one allograft. It's the reason why when I start, I use a fascia of the infraspinatus, but you have to extend the incision, and this is a bad incision at the back. Or you have to use a semitendinosus tendon, and you harvest 20 centimeters to obtain a dual graft of 12 centimeters. You see that you can do a semitendinous graft with a stripper, and you obtain 20-25 centimeters, and you can do 10 to 12 dual graft, and is enough to extend the lower trapezius and to reach the footprint of the infraspinatus. The key point of this technique: be aware to the spinal nerve, and my recommendation is to locate it with the nerve stimulator. Is very important before to do a large dissection. You harvest the graft, and the key point is to first the graft first at the infraspinatus level with 2 anchors. Why 2 anchors? Is to have a good contact between the tendon and the bone. And if you have a surface of the footprint to applicate the tendon, the graft to the footprint is better. The tension should be maximum, and you have to put the arm in external rotation maximum when you tight the graft to the lower trapezius. And for me, it's very important to immobilize the patient. And now you can use a custom-made brace with a cast to have this position. And the patient keep this cast during 6 weeks in external rotation before to start the physiotherapy. And after, I recommend to keep during the night 6 weeks more. I show you a video. You see that this is a live surgery. I did the first dissection of the lower trapezius. And you see that just under the skin, you can isolate the lower trapezius. And after, you isolate the tendon of the lower trapezius to divide the lower from the medial trapezius. Be aware of the nerve. This is a nerve. Okay? And you detach the tendon and and you have a big muscle. You see that you have a big muscle, and you have the nerve here, the pedicle, the tendon of the lower trapezius. And you see that you have the medial trapezius here, you have the lower trapezius here. This is a big muscle, and you can extend it with a semitendinous graft. It's very, very easy operation because the muscle is just under the skin. You prepare the tunnel just in front of the posterior deltoid and just behind the infraspinatus, who is atrophic. You have to open the aponeurosis of the infraspinatus to have a good way. It's very important. You take the semitendinosus. You know very well if you do knee surgery, and you know this technique with the stripper. You harvest 20-25 centimeters, and you reinforce. You see that the sequelae has mobility of the harvesting is very, very small. I reinforce with a crack of suture. You see that, and I put 2 anchors to the humeral head. You see that I have 2 fiber wire, one distally and one proximally frontal. And I use a knotless anchors. This is the direction. Okay, you do your arthroscopic release. You try to repair partially always. It's not so easy. You see that this is a teres minor. It's not working very well. There are many adherences. This is the labrum. You see that is not repairable. And I put my my tendon allograft. You see that? This is the allograft. This is a semitendinosus. Sorry. This is a semitendinosus. And I fix to the anterior part of the foot of the infraspinatus with anchors, like that. And after I fix my second anchors posteriorly, I fix the first anchor here. This is a knotless. And after I fix the second anchors with my posterior portal, and I have 2 points of fixation on the humeral head. It's very important. This is my second anchors, you see. You see that there is a 1 or 2 centimeters contact to the bone with the graft. It's very strong fixation. And after you can use a partial repair. You see that here you have I use a partial repair with my shutter. I use a partial repair here. I try to advance the teres minor. And after I fix it, the arm is in external rotation, and I do a pulver taft technique. This is a pulver taft technique. And I fix it, the arm in external rotation. Maximum tension is very important to put a maximum tension. You see that? And after I use the pulver taft technique with non-absorbable suture, And after you try to see the excursion. You see the excursion? When you move the arm, you have a good excursion of the lower trapezius. The excursion is close to the infraspinatus. So this is a publication of 15 cases, monocentric study. It's not so frequent, the indication. And my indication was in 12 cases, supra-infraspinatus and teres minor deficiency, 1 reverse with a lack of external rotation, and 2 cases of myotendinous infraspinatus lesion with a weakness external rotation. I use semitendinosus, fascia of the infraspinatus, And in 4 cases, I combine latissimus dorsi and lower trapezius transfer. This is very interesting to see that the dropping sign on the hormonal sign were corrected in 100% of the cases, in 15 cases. And you see that the gain in external rotation was 44 degrees. Before it was negative. Systematically, we have no failure in this series, on 70% on constant score 60. This is a case of a patient, you see that is very important, atrophy of supra, infra, and teres minor with a painful shoulder, limited external rotation, and no active external rotation. And this is a result of this case after 1 year. You see that he has active external rotation, is 20 degrees, 30 degrees in abduction. And this is another case with also excellent result. And it's very important to see that there are good medial rotation, and it's important. So there is no significant difference if you use infraspinatus fascia or semitendinous. This is not necessary to combine latissimus dorsi transfer on lower trapezius. I have no advantage to combine, in my experience, 2 hematoma, but the problem is a small series. Lower trapezius is very effective for relief pain, for restoration of active external rotation. And this is my indication, supra, infra, teres minor deficiency with a good subscapularis. Another way described by Pascal Boileau is episcopo. And he used episcopo isolated without any reverse arthroplasty if the patient has a good forward elevation, but no active external rotation. This is a hormonal sign. And in my experience, the results are less than lower trapezius, but I think that you can use sometimes. And you have no teres minor. You see that there is no supra, no infra, no teres minor. And you can do a small incision here. You detach the latissimus dorsi and teres major, and you turn around the humerus and you fix opposite to the insertion in the posterolateral part of the humerus. And not too much anteriorly, not to limit the medial rotation, but you can fix posterior and posterolateral. So this is the result, but with more follow-up, my result decrease. And it's the reason why I think that the good result is very transitory in my experience. And I prefer to do a lower trapezius transfer. So if you have no active elevation, no active external rotation, if you have a pseudo-parachoked shoulder, I use episcopo and reverse shoulder arthroplasty. It's very good indication. You see that this is a patient. He has no external rotation. He has no forward elevation. He is completely full range of motion, passive range of motion. For me, this is a typical case when you do reverse, you have to combine to tendon transfer. Because if you do reverse, you restore elevation, but you don't restore external rotation. External rotation, you have to do episcopo procedure. This is this patient, you see that is completely atrophy in posterior superior and teres minor. You can do episcopo. The key point is to repair the subscapularis, to spare the pectoralis major or to repair the pectoralis major, and to fix the tendon transfer posterolateral position opposite to the insertion of the tendon, not too much anteriorly, because if you put too much anteriorly, you limit the medial rotation. You have to respect the pectoralis major to share to the pectoralis major. It's very important to avoid anterior instability. If you do episcopo and you have no subscapularis, you have a risk of anterior dislocation of the prosthesis. I think that you have to repair the subscapularis, you have to spare the pectoralis major. This is my experience of 31 cases. You see that you have a constant score on 75, you restore external rotation, 90 degrees, 37 degrees, and you restore active elevation. And you see that the function of the shoulder is 68%. I published this series in 2013. The conclusion of this lecture for me is very clear. If you have a massive irreparable posterior superior curve tear with a good teres minor. The shoulder is painful. The patient did 3 months of physiotherapy, and you see it again, and it's not very painful. It's very painful. It's not happy. You can propose a latissimus dorsi transfer to improve forward elevation and to improve external rotation in abduction. If you can repair partially the curve, is better, and we recommend to combine latissimus and partial repair as a curve augmentation. If you have no teres minor, if you have no active external rotation, the arm and the body, you have to propose lower trapezius transfer, and you restore external rotation, and you restore also forward elevation. If you can do a partial repair, it's better for the patient because lower trapezius is a curve augmentation. The last point is how to restore active external rotation. If you have a limited active forward elevation, I use latissimus dorsi because latissimus dorsi restore external rotation in abduction, a little in external rotation, or you can use lower trapezius as you want. If you have no active external rotation but a complete forward elevation, I think that you can do lower trapezius, or Pascal Boileau described episcopal, but I think that is less effective than lower trapezius transfer. If you have no active external rotation, if you have no active forward elevation, this is a pseudoparetic shoulder, you can restore elevation with reverse, external rotation with episcopal. I try to simplify because I think that is important to know the indication for your patients. And my goal is to improve your practice when you have a patient in front of you and when you decide a tendon transfer. Thank you a lot for your attention, and I try to answer to your question, and I hope so that I can invite you next year in the best period without any coronavirus to be in presential in Paris and to see the Eiffel Tower and to follow the meeting. But I will do this meeting also in virtually to open the meeting over the world for many people who cannot travel very easy. Thank you a lot for your attention.
Thank you, Philip. Indeed, a wonderful presentation. If you can unshare the screen, we can have some questions. Thank you, Philip. Maybe we can initiate discussion. Philip, there is a question here. It says that when you do an episcopal operation and you think you can't repair subscapularis, you would abandon that operation, you won't do it?
In this case, I transfer the pectoris major in position of the subscapularis.
Okay, so that's a pec major plus episcopal.
Yes, yes.
Okay.
I think that you have to reimbalance the shoulder. Yes. If you put two external rotation posteriorly, you have to maintain anteriorly medial rotation. Yeah. I think that the balance is very, very, very important.
Yeah, Sundar, yes.
No, regarding the forward elevation, because you showed one case, you even have a complete drop arm sign, you are done, I think, lower trapezius transfer. So why you have to combine latissimus dorsi in trapezius in some cases where you need more forward elevation? Why can't be just lower trapezius?
Yes, I try to combine both, but the result is not so good. It's not better. I think that lower trapezius is working very well in abduction because the direction, the excursion of the latissimus dorsi is good in abduction. When the arm at the body, the latissimus dorsi is more medial rotation, is adduction, but is not external rotation. And it's the reason why I think that if you have a lag sign or a dropping sign described by Neer, I think lower trapezius is more useful, because when you do external rotation and you feel your lower trapezius, there is a co-contraction. It's very nice. And I didn't see any dyskinesia of the scapula, because some surgeons say if you take the lower trapezius, you create a morbidity of the donor side. Is not true. I did more than 30 cases and I have no dyskinesia of the scapula. I think if you respect the serratus anterior, if you respect the rhomboid minor on major, you have no dyskinesia of the scapula, and you can harvest very, very easy the lower trapezius.
Philip, how are the results? I mean, do these results improve with time or they deteriorate with time? Say, suppose 5 years down the line, 6 years down the line. So what is your experience? Because you have been doing it for long years now.
Regarding what?
Regarding any kind of tendon transfers, because this is something which is not the normal direction and the work of a tendon, and we are actually transferring it to another direction. So do these results actually deteriorate with time, or once you achieve good functions, they retain function for a long time?
I think that with the long time, with more 10 years follow-up, I follow the latissimus dorsi transfer, and there is no decrease of the result.
Okay.
The result is maintained. I think that the main problem is a preoperative preparation. I think that you have to do a good education for the patient to reinforce the latissimus dorsi, to stimulate the latissimus dorsi, to motivate the patient, because many times some patient doesn't understand what happens, and there is not a good result of latissimus dorsi. Because it's not an agonist. It's not an agonist. Yeah. It's not an agonist.
Philip, I've got a question to you. When you told about that after your lower trapezius transfer, you just plaster that way to keep the external rotation for 6 weeks. Is this the way you are following for this, or this is for just recent years you are doing this?
Yes, I think for me, immobilization is very important. If you don't do immobilization, you have a lengthening of the suture into the lower trapezius, and you lose external rotation. And I think that the custom-made brace is better than the brace that you can buy in the market, because if you put a brace that you can buy in the market, you remove the brace every day to take a shower, and you have a medial rotation of the arm, and there is a risk of rupture. And now with the cast, you have to keep it. You have to keep it 24 hours. And I think that is better. And for the patient is a difficulty, but it's not a big difficulty. They accept before to do the operation.
Philip, I will ask you a very, very simple question, might be looking silly, but when we started doing this lat dorsi transfer, always we are very scared about how to dissect the lat dorsi transfer and how to take care of the radial nerve. Basically that tendon, when you take care from the humerus, we are all very scared. That's why we attend the cadavers to know how it should be dissected. Just your expert opinion for the juniors and colleagues.
Yes, I think that if you do an axillary incision, you have to isolate the white aponeurosis band, and you have to stay close to the aponeurosis band, because you have the axial nerve superiorly and you have the radial nerve inferiorly.
Yeah.
And it's very important to put the arm in medial rotation, because when you put the arm in medial rotation, you push away the nerve. It's very important. When you have in abduction, you put in medial rotation and you push away the nerve. And for me, I don't want to see the nerve. I stay close to the aponeurosis band, very close, and you have no problem of the nerve. The second problem is when you do episcopo. When you do episcopo, the first nerve is a radial nerve. I agree with you. It's 6 centimeters. It's 6 centimeters from the humerus. It's very close. And you have to see it when you do episcopo, because the radial nerve is very close. And when you do the dissection medially, you have to do iatrogenic lesion of the radial nerve sometime. I agree. Be careful to the nerve.
Yeah, because that is very close to the tendon. Yeah.
Yes, of course.
Philip,
Dr.
okay, Pratik.
Yeah, Pratik, please.
Just had one question. For those cases where you have supra and isolated infra, but with good subscap as well as teres minor and deltoid, what are your views? Do you have experience with superior capsular reconstruction, or generally, what is your indication for superior capsular reconstruction? Patients have pain and reserved.
My indication is for superior capsular reconstruction is very. This is a passive for stabilization of the humeral head, is not active. On the second point, I think that you can use when there is no supraspinatus, or you have a rupture of the supraspinatus on half part of the infraspinatus, you can use a superior capsular reconstruction. I think it's a good indication for me. But if you have no infraspinatus, if the fatty infiltration is free, I don't use it. If you have no supra on half of the infraspinatus, I use superior capsular reconstruction. But I use the fascia of the femur, fascia lata. I use fascia lata. I prefer fascia lata than the patch in the compagnie. I think it's better because this is autograft.
Yeah.
And for the fixation on the, I think that Miyata is represent good result because he used fascia lata, and he used a very thickness fascia lata. I discussed with him, and he does 9 liner of fascia lata. It's very fat.
Keeps rolling, yes.
Yes, this is rolling. And I think that is good. And for me, I use, and I did a short series of combination of latissimus dorsi and superior capsular reconstruction with very nice results. It's a long operation, but you put the fascia lata at the place of the infraspinatus, of the supraspinatus, and you put latissimus dorsi at the place of the infraspinatus, and I have a very nice result. I did 5 cases, and there is a space between the humeral head and the acromion, and I recommend sometimes to combine the two techniques. I did 5 cases, and I continue now to do, and to compare to isolated latissimus dorsi transfer. Because after 10 years, you have arthritis between the humeral head and the acromion. The latissimus dorsi is not enough strong to go down the humeral head. And my goal is to maintain the humeral head with the fascia lata technique of superior capsular reconstruction and latissimus dorsi for the strength, active tendon. I think that you can combine it. But I don't recommend the patch of Artrex or many companies because it's too expensive. In France, it's 800 euros, is unacceptable for me. And fascia lata is very cheap.
So Philip, as I could understand that the ACR you are recommending only for your irreparables, your supraspinatus?
Yes. But it's very rare because if you do tenodesis of the biceps and acromoclasty, many times is enough.
Yeah, many times you had a question?
Sundar.
Yeah, so Philip, when you showed results of latissimus dorsi, you had showed better results when you had done the partial repair. So in when you combined LD transfer with the lower trapezius transfer, how many cases could you able to do the partial repair or a complete repair?
I think that we can do more than 50% of partial repair. More than 50% of partial repair.
Okay.
But the key point is to analyze the fatty infiltration of the infraspinatus, because if the fatty infiltration is more than 3, I think that if you do partial repair, it's not useful.
Okay.
It's not useful.
Philip,
Because many times, yes.
Yeah, sorry.
And in revision cases, you told that you had a latissimus dorsi transfer. do you add lattice mesh transfer in all revision cases, or how do you decide about the quality of the tissue, or do you decide about the tissue or quality of the tissue?
No, I did a presentation last meeting. I compare new repair on latissimus dorsi transfer and latissimus on partial repair. And the conclusion was that if the fatty infiltration of the infraspinatus is less than 2, you can do a new repair. If it's 3, 4, you can do a latissimus dorsi transfer. I think for me, the key point is the analysis of the infraspinatus. Because if the infraspinatus is atrophic, you have no chance to repair and to obtain a good result. You can restore elevation, you can restore pain relief, no strength in extra rotation. The patient is not happy. If you combine with latissimus dorsi, you can restore more strength in extra rotation.
Philip, any experience of using in-space balloon along with the tendon transfer?
No, I have no experience. I use balloon when I repair the cuff. When I repair the cuff, I use a balloon. Because
I was wondering, instead of an SCR plus a tendon transfer, which you said is a very big operation and it takes time, why not do an in-space balloon and a latissimus dorsi transfer?
Yes, yes. But the balloon is very expensive in France. And the Social Security doesn't reimburse. No. And it's more than 1,000 €, and the patient doesn't accept to pay. What's happened in India? In India, is free?
No. It's nothing is free.
Nothing
in
is
this
free.
world, nothing is free.
Nothing is free. If it is not free in France, it is not free in India.
Yeah. Sundar, yes, you had a question, Sundar.
Yes.
That day when George Atwal was presenting the lower trapezius transfer, he showed the different technique, like where he shows that sometimes the bone quality is very poor, so he usually makes a tunnel and put a button. So
Yes.
Have you experienced that about the quality of the bone, because you are using only interference screws?
No, I at the beginning I used a tunnel, but I had a rupture of the lower trapezius at the junction, at the entrance of the tunnel. It's the reason why I decided to stop it. And I use not less of 60.5 from VIMS. And now I have no problem with the bone. I have a good quality of these anchors. This is 6.5 is a lot. And this is a double screw with a good fixation, and I use that. And I don't do a burr. Many surgeons use a burr. No, it's not good. You have to use a shaver only to remove the soft tissue, but you have to keep the cortical bone. Because if you analyze the insertion of the normal tendon is inserting on the cortical bone. It's not inserting on the soft bone. Why you remove the bone? Sometimes I do some holes, small holes, but I don't remove the cortical bone now. I finish that. It's not necessary.
Thank you.
So I think there are no more questions here in the chat box as well. So if you can, Sundar, just conclude and we can then say thanks.
Thank you, Dr. Phillipe. I think it's a wonderful talk, and we got in our mind clear indications when to do a lower trapezius transfer, when you do a latissimus dorsi transfer. I think you have a fantastic indications, especially your conclusions was very, we have very good clarity now when to choose LD transfer, when to do a combined transfers, and when to do combined with the reverse shoulder. Thank you, Phillipe, for your time. And I want Samatha, our secretary, to thank Phillipe and finish the program.
Thank you, Phillipe, primarily for agreeing, and this is a great honor for the Indian Arthroscopy Society. And your talk was just mind-blowing, because I think even we learned that what is the proper indication doing the LD and what to do the lower trapezius. And we are really honored as the secretary of the Indian Arthroscopy Society. It's a big clap from everybody on everybody's behalf, and it is a great honor when we'll be able to physically meet and attend the conferences. Definitely in 2021, we'll be meeting in Paris. Thank you very much.
Thank you, Philip. Thank you very much.
Thank you a lot. You have a very nice friend, and I invite you in Paris as soon as possible. Thank you.
Thank you.
Thank
Take
you.
care. Take care. Take care. Bye bye.
Take care. Good evening. Good evening, my friend.
Yeah, thank you. Bye.
Thank you very much for
Thank
indeed
you.
a wonderful presentation. We must thank Philip and Sundar for hosting this meeting. Friends, we have our basic arthroscopy series, which is going to be hamstring ACL reconstruction. Dr. Ravi Gupta, eminent surgeon from Chandigarh, senior arthroscopy surgeon, is a part of it.